So we're going to segue and in our topics, and I'm very pleased and privileged to welcome back Massimo Gadina from the NIH. He reminded me, I was trying to get my brain to work, so like when the last time he was here, it was a decade ago. So he must have been here for Biologics 5, and so much has happened since that time. That was about the time when we were just starting to get into using first JAK inhibitors clinically, and you know how time has changed. So Dr. Gadina is director of the Office of Science and Technology at NIAMS, and he has done some really interesting and important work in the space of cytokine biology. So I've asked him to kind of pick up where we are now. We've all been using JAK inhibitors. We now have a handful. The number of indications are growing, but there's a next generation. There's an emerging biology here. And while we have a foundation in clinical utility and we have some pretty good perspective on toxicity profile, we want to know what's coming next. So Massimo, the pressure's on.
Thank you. Good morning, everybody. Thank you very much, Len. Thank you for the kind invitation and the persistence, because, you know, what you don't know about me being here is that Len invited me, sent an email, and it went into my spam folder. And, you know, a few days, weeks later, Len, you know, emailed me back and said, "Did you see this email?" I said, "No, sorry, I didn't see that. Apologies." But yes, I was here 10 years ago, and as Len mentioned, that was really the beginning of the JAK inhibitors story in a certain way. 2 had just been approved. Now there are a few more, as you will know. Let me start by explaining my initial slides here. I have 3 pictures of Janus. It gives the name to the class of drugs. And I'm going to use these 3 different Janus during my talk to, I'm using the Roman god, which is actually in the Vatican Museum, but I stole it from Google. I didn't see that myself, for the first generation JAK inhibitor. This is a Marc Chagall painting, actually part of a Marc Chagall painting that I saw at the Guggenheim Museum when I was visiting a few years ago. I saw it in a corner of the painting. I think the name of the painting is Paris Through Windows. And I said, this is perfect for my presentation. And I usually have only 2. And then in September, I went to give a talk in Ghent at a spondyloarthritis meeting. And there was this Kurt de Vlam, who is a Belgian rheumatologist, who after the talk came to me and said, you know, I think you have to introduce a 3rd generation JAK inhibitors. And I can tell you exactly what picture to use. And so this is a painting from Piet Peer, a Belgian artist, and also has a different Janus here. So I'm going to use these 3 during my presentation. So I think if you go away from this presentation with just one thing, it's just, you know, this slide here, because it illustrates the complexity and also why this is an area which we've been working on. So cytokines come in different flavors. Cytokine receptors come in different flavors, of course. But here we have the type 1, type 2 cytokine receptor, which I'm going to be focusing on today. And this receptor utilizes the so-called Jackson-Stat pathway. I'm not going to go to the details, but, you know, what you can walk away and we need to remember is that there are 4 JAKs, JAK1, JAK2, JAK3, and TYK2. I've seen some places where, you know, TYK2 is defined as a different kinase. No, it's a JAK. Actually, it was the first JAK to be discovered to be cloned. And then the other came after, but they took on a different name. This is just to make you more confused. They all belong to the same family, same structure, very, very similar. JAKs work in pairs, as you can see from the cartoon above. Different receptors binds different JAKs, and there also activates 7 stats downstreams. And because of this multitude of JAKs and stats, different immunomodulatory signals are generated. But why are we targeting these JAKs, these molecules, to treat autoimmune disease? I think this is the main reason. So these are examples of for inflammatory mediated immune disease, as Len calls them. And these are the cytokines that have been shown in various studies, human, preclinical, in vitro, whatever, to be involved in the pathogenesis of these diseases. And as you can see, most of these cytokines utilize one or more JAKs in their signaling cascade, or two or more JAKs in their signaling cascade. And that's why this became a very interesting target to go after from the point of view of treating inflammatory diseases. This is the status of, the scorecard of the JAK inhibitors that we have right now. These are the one that have approved. Actually, there's one more, but it actually has been approved to treat allergic dermatitis in dogs. So I haven't listed it here. Yes, there is a JAK inhibitor for dogs. And every time, and I actually story that I'm not going to tell you today, I always show my first clinical success, which is actually suggesting JAK inhibitor for a dog, and to a colleague that I work along, and she came back after a few days saying, "You changed the life of my dog." It's really a great drug for dogs. But these are the JAK inhibitors that are approved for a whole variety of inflammatory disease, and even, COVID-19 with baricitinib approval, emergency approval to treat patient with COVID-19. And these span all three categories, first generation, second generation, and even third generation. Deucravacitinib recently been approved for treatment of plaque psoriasis and also been investigated in other diseases as well. But so Len asked me to talk about where are we going now, but let me introduce first a different topic before, telling you where the field is going. Move forward. Okay. So how do JAK inhibitors, the first generation JAK inhibitors work? Sorry. Okay. Yes. Okay. First generation. So the first generation JAK inhibitors works by competing with ATP. So this is the binding pocket of JAK3, actually, or a construction of the binding pocket where ATP normally sits. ATP is in red and green, and tofacitinib is in blue and pink, as you can see here, overlay. So by inserting itself into the ATP binding pocket in the kinase domain of JAK, JAKs are phosphotransferases, so they take ATP and attach phosphate to the residues, more tyrosines residues in their substrate, in the preferred substrate. By competing with that, what happened is that the cascade downstream, for example, cytokines or interferon, it's blocked, so STATs can no longer be phosphorylated. They no longer travel to the nucleus to activate gene transcription and to induce inflammation or whatever, autoimmunity, in what we're interested, of course, today. So how do they work in terms of biology, at least what we know right now? First generation JAK inhibitors inhibits multiple JAKs, so they're sort of pan. They go after different JAKs, and by blocking cytokines like interleukin-6, interferon gamma, and type 1 interferon, which utilize the JAK-STAT pathway, indirectly they also block the production of cytokines which do not utilize the JAK-STAT pathway, like TNF and IL-1 production. Their major effects are on T and B cells, differentiation of T helper cells. There is a decrease in T and B cells, but then, they slowly recover. And NK cells as well, of course. But interestingly enough, and this is something that I say all the time, and I'm going to say it again, this is my line is that this is job security for me. We still don't understand the cell, state-specific dependency of any given JAKs for any particular cytokine. This is something that we still need to understand completely. Talking about selectivity, how do you measure selectivity? I said that, the first generation are, not that selective. But what does it mean, selectivity, and how do you measure selectivity? So this is a cartoon that I got from a colleague of Pfizer. We collaborated with Pfizer for many, many years. The collaboration is no longer ongoing, so I don't have any disclosure on that. So they tested all these kinases here. This is the human kinome, 519 kinase that we have in our genome. So wherever you see a dot, the people at Pfizer took the recombinant kinase domain, treated with tofacitinib in this case, and then measured the IC50 for this specific kinase. And the green dot here, which I circled in red, is actually the JAKs. And those are the kinases that are inhibited at the lower concentration. We're talking low micromolar concentration. In general, as you can see, they don't have a lot of effects on other kinases in general, not, or at least you require a much higher dose. Tofacitinib is the one developed by Pfizer, it's a JAK3, JAK1, and to a certain extent, JAK2 inhibitor. It doesn't really block TYK2, and that is something they were kind of sure. Baricitinib and ruxolitinib, two others that have been approved. Actually, ruxolitinib was the first JAK inhibitor to be approved to the treatment of polycythemia vera and myelofibrosis. They are known as JAK1, JAK2 inhibitor, but let me get into that in a second. Because the point is that how do you measure selectivity? What does it mean? How do you do the assay? You can do it like here, in an in vitro system, recombinant kinase domain, and the drug, and you measure the IC50, or you can do it in an in vitro assay like this, or you can do it in cells, you can do it in mice. You can give it to a preclinical model, and then, measure that in IC50, or you can measure it in people taking the drugs. We now, have a lot of these inhibitors that I show you are now approved. The problem is that you don't necessarily get the same answer depending on which assay you use. And the example that I'm going to show you to you is actually come from a review that was written by Kemi Brito a few years ago. I think he's going to speak tomorrow, not about this, but this is a very interesting review. I use it all the time, and I actually saw him to a meeting last month, and I thank him for, and he was very happy that I was showing his table. But let's just give you an example. So I told you that baricitinib and ruxolitinib are known as JAK1, JAK2 inhibitor, right? And in fact, if you do an enzymatic assay, these are the IC50, very, very similar numbers that you see here. But if you do the assay in a different way, so by incubating PBMCs and then looking at the phosphorylation of stats, you can really measure phosphorylation of JAKs very easily. They're not great reagents to be used, but you can actually measure as a surrogate the phosphorylation of stat, and you can do it, by flow cytometry very, very easily. We do it all the time. So if you do, for example, measure the IC50 of these two JAK inhibitors on cells that have been stimulated with interleukin-15 and measure phosphostat 5 or interleukin-6 and look at phosphostat 1, then you get very different numbers, as you can see here. Or even, when you look at EPO, which actually utilizes a dimer of JAK2, you get different numbers. So yes, we call them JAK1, JAK2 inhibitors, but the reality, it's not that clear. It's not so straightforward. To complicate even further, let me show you this piece of data. This is a paper from Ian McInnes that he published just before the pandemic. It's a very complicated essay. I'm not going to go into too much details, but just to give you an idea. So they did measure the IC50 for a lot of JAK inhibitors. In this case, we have baricitinib in this figure, baricitinib, povorcitinib, and tofacitinib at 2 different doses. This was done in vitro on different cell type, utilizing different cytokines, and that put those data away. Then they took the pharmacokinetics of these drugs in human, and they kind of superimposed in a mathematical model the time in which the concentration of the drugs in humans were above so the IC50 was above the concentration of the drugs in humans. So when you take interleukin-21, stimulate NK, and look at NK cells, IL-21 utilizes the gamma-C common gamma chain, so it utilizes JAK1 and JAK3. And so it's not surprising that the drug that stays above the IC50 the most of the time is tofacitinib, which is JAK1, JAK3 inhibitor, preferentially, at least from the in vitro assay that I just told you. Baricitinib, JAK1, JAK2, at least from the in vitro assay, doesn't go over the IC50. The IC50 is not reached. Upadacitinib, a little bit in between. But again, it's more complicated than that, because if you do the stimulation with GM-CSF, which utilizes a JAK2 dimer in their signaling, surprisingly, the drug that stays above the IC50 is a quote-unquote JAK1 selective inhibitor, at least what's been described as JAK1 selective inhibitor. To me, this tells me that, again, it's a complicated story. We don't understand completely, and probably that upadacitinib is not really JAK1 selective. It's more JAK1 and JAK2 quite a bit inhibitor. So again, another laundry list of drugs that are being developed. We are talking about, what's coming down the pike. A lot. As you saw before in the presentation before me, a lot of anti-PD-1 developed by many companies. There's space, there's market space. And many companies are investing into developing, again, first/second generation inhibitors, because I call them first/second because these are orthosteric. And I'll get you in what I mean by that in a second. So these are drugs that compete with ATP, like I showed you before, in the pocket. They go inserting cells in the pocket in the kinase domain of either JAK1 or JAK2 or JAK3 or even TYK2. So there are a lot of them being developed for a variety of disease, not only rheumatoid. Some of them actually have been approved, like UPA, Filgo, and abrocitinib approved for a variety of diseases ranging from gastrointestinal, IBD, and so on, skin, of course, and many others. And of course, the JAK2 selective are more geared toward trying to find, therapy for malignancy, mostly hematologic malignancy, but also other cancer as well. And then also what you can see here is that, we call them JAK1 selective, but many papers now have come out showing that some of these are really not so JAK1. And actually, some of them, come through full disclosure. The companies that develop them tells them, is a JAK1, JAK2, or a JAK1, TYK2, or a JAK1, JAK3 inhibitors. They know that, at least based on some of the in vitro assay that I told you before. Then there is the JAK3 selective groups. JAK3 has been a little complicated, falling a little bit behind. Ritlecitinib, developed by Pfizer, is JAK3, and then there's this company developed by a Chinese company, JAK3, and maybe Tech Kinase. So this is interesting because what Pfizer did with ritlecitinib is going after a covalent binding. This, something that sticks in the pocket, you can't get rid of it. So technically, would have brought the major advantage, which, it has a problem with JAK inhibitors. They're very rapidly clear. A covalent binding would have actually allowed for a prolonged half-life, in theory. It's not that the case, and I'll get you in a second. So this is how ritlecitinib, it works. As I said, it's insert itself in the same binding pocket and also has its interaction with cysteine 909, I think is, if I remember correctly, the number of amino acid. Interestingly enough, this cysteine in the ATP binding pocket, it's present also in other kinases, in particular in the TAC family of kinases. So TAC, BTK, ITK, BMX, and so on. So ritlecitinib developed as a pure JAK3 inhibitor. It also blocks these kinases. It actually could be a bit of an advantage from the clinical point of view because many of these kinases actually are involved in the signaling cascade of immune cells, so they might be a good target to begin with. The problem is that, as I said, is the idea was going after a covalent inhibitor that would stick to the JAK3 and therefore block it for a longer time. But what the group they discovered at Pfizer, JB, or my friend JB, and so on, discovered later on is that JAK3 is very rapidly resynthesized. So yes, you block it, but new JAK3 is being synthesized very rapidly. So even, covalent binding does not translate directly in the longer pharmacokinetics, unfortunately. There are also inhibitors that have been developed to block not only JAK kinase, but other kinases that are involved in other immune, signaling cascade. So, for example, guzacitinib and sertolatinib block both JAK and SYK. And SYK is involved in BCR signaling, FCF receptor signaling, and integrin signaling as well. These are drugs currently in development, phase 2, phase 3, mostly for, sertolatinib mostly for malignancies, but also for skin pathologies like vitiligo. The recent data about guzacitinib, it's actually very good for treating chronic hand eczema. And also we are about to start at NIAMS a small trial, phase 1B, of guzacitinib in SLE as well. Then there is a different approach that you can also take in terms of selectivity, and not going after selectivity in terms of kinase, but also in terms of organ selectivity. I think that's actually a very interesting idea. And there are kind of two areas in which, JAK inhibitors are currently developed. One is non-absorbable, meaning that they go through your gastric tract intact, they don't get, destroyed or anything. reach the gut, and that's where they act. And in fact, is axitinib or ST122, they are being developed to treat IBD, Crohn's, and ulcerative colitis. Or, of course, given also the interleukin-5, interleukin-4, and so on, which are very important cytokines for allergy, atopy, and allergic diseases, they are the inhaled form that are being developed. And these are a list of them. So, again, not these are most of them, are, either pan-JAK or, JAK1, so on. But again, selectivity has to be taken with a bit of grain of salt, as I told you. But in general, they're saying these are good to, to be inhaled, and so potentially to act in the lungs where, most of the inflammatory situation happens in the context of an allergic reaction. Okay, let's move to the third generation, and this is my pear cartoon appearing up on the right corner. So what this approach is, instead of using an orthosteric blocking, so the ATP competition that I showed you before, so this was in this case for these drugs, an allosteric mechanism was designed. What does it mean? It means, so JAK have a structure in which there is the kinase domain, also known as the JAK homology domain. This is, we're going back into the mid-90s when JAKs were discovered. JAK homology domain is followed by a pseudokinase domain, used to be called JH2 domain. The pseudokinase domain for many years has a very similar, structure, but for many years with what it was thought to be totally, not active. Then, patient with mutation in the JH2 domain was shown to develop polycythemia vera. And that showed that actually JH2 domain or the pseudokinase domain is very important in order to control the autophosphorylation capacity that JAKs have. So the idea was to block the JH2 domain and the pocket that JH2 domain possess in order to block the autophosphorylation that JAKs does on their own molecule, itself. And so that was led to the development of deucravacitinib, which I just told you has been approved for plaque psoriasis and studying currently in trials for other diseases. And a bunch of other companies are developing, allosteric blockers for TYK2 in particular. And then there is this very recently, this is actually something about a few months ago, this paper, which I'm going to show you in a second, came up describing this new compound, VVD 118313, mouthful. Don't remember, it doesn't mean anything, it's not important, but I think it shows the potentiality of going after the same situation of, allosteric inhibition in other JAKs as well. And it was a very smart approach because it was done first with a chemical proteomics screening that led to the discovery of the fact that you can go after a cysteine in the JH2 domain, the pseudokinase domain, cysteine 817, which is actually present in JAK1 and in TYK2. And the group at the Scripps Clinic, developed this compound here that inserts itself into this pocket, which has the cysteine at the bottom, which is actually structurally similar to a binding site in the ABL kinase where the myristoyl insert itself, and for which actually has been exploited in oncology, and asciminib is actually developed exactly for that particular reason. This is actually asciminib in the pocket of ABL, very, very similar approach. And so these are some, I'm not going to go to the paper. The paper is long, and you can get the reference and read it yourself. It came out late in 2022. But just to give you an idea, so 5A or whatever the number they've used in here is actually the compound that I'm talking to you about, the VVD. Actually, you can see it blocks the phosphorylation of STAT1 induced by interferon alpha at much lower dose, for example, than upadacitinib, which actually, quote unquote, was described as JAK1 inhibitor, and similar to the other, because as I told you, that cysteine is also present in TYK2. Actually, the 5A, it's a derivative of ABD, and it blocks both JAK1 and TYK2. So similar to the BMS compound. This is actually the deucravacitinib. you need much higher doses of tofacitinib and itacitinib to achieve the same effect that you have with this compound. If you look at STAT1 phosphorylation response to interferon alpha. Similar thing with IL-6 and STAT3, and interestingly enough, for STAT5 activated by IL-2, then things change, because then it's the same potency that you get with upadacitinib, and actually very similar also, actually better, even better so for tofacitinib, because you also block JAK3, which is involved in IL-2 signaling cascade. And when you look at GM-CSF, which vice versa, I told you before, it utilizes a JAK2 dimer, then this JAK1 inhibitor doesn't work at all, whereas the other drugs do. And it's not only a matter of proximal signaling, which is measured by this assay. You can actually look at what happens in the cells in terms of production of pro-inflammatory cytokines and chemokines, and that's what they've done in this experiment here. And they've showed that this compound is actually capable of blocking chemokines like MIP and IP10 to the same extent of tofacitinib and deucravacitinib. So I think there is this story showed there is the possibility of pickpocketing JAKs. So going after not only the kinase domain, which was done to begin with, but also pseudokinase domain. And I think it opens up the possibility to target other domains. For example, what about the firm domain, which actually is utilized by the JAK kinase to interact with the cytokine receptor, which is critical for the activity of JAKs? Can we interfere with that? Is that going to be sufficient? Are there other pockets that are amenable to this electrophilic interaction, which is what this particular compound shows? There are other residues, lysine, histidine, methionine, that can be targeted in one way or another. So I think there's a lot that we could probably do. And again, I'm going to use it again. Job security, especially for them, they're doing this chemical biology approach, trying to figure it out what can be done. And then as I told you, this pocket when this compound inserts in the pseudokinase domain is analogous to where the myristoyl bindings to the ABL. So in the discussion, the authors mentioned the possibility to look at endogenous metabolites to block JAK kinase activity, JAK activity in general. And sure enough, when I was here in 2013, the speaker after me, I think, if I remember correctly, or maybe two speakers after me, was actually Luke O'Neill from Trinity College. And maybe you remember, Len, that you invited Luke. And actually, this is interesting because Luke had just published this paper. Luke has been interested in metabolism and metabolism macrophages for many, many years. And he showed that, itaconate, which is actually one of the byproducts of the Krebs cycle. I don't want you to remember that, but, itaconate and derivative of itaconate is actually capable of blocking JAK1. And, again, the paper is very thick, very intense. I'm not going to go into the details, but it interacts with cysteine 816. This is the mouse JAK, and becomes 817 in humans. Interacts with this cysteine in the pseudokinase domain, and similar to what I showed you for the small molecules before, it blocks the activity of JAK1. So there is a possibility, what was predicted by the author of the other paper actually turned out to be true. But of course, this was a study mostly done in vitro. There was a little bit of in vivo component, but not much. But then this paper came out, a few weeks ago, showing that in fact, itaconate can ameliorate autoimmunity in animals. This is EAE, and it ameliorates EAE in mice, and it does it by interfering with the genetic and epigenetic program of Th17 and T regulatory cells. Again, opening up, this is where the field is going. We're not limiting to small molecules. We need to broaden our view. We need to look at other things. And, clearly, the compound that was developed, the itaconate derivative that Luke put in this paper, it's just, similar to the VVD compound. It's not a great compound because it had very, 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 very short half-life, I think, half an hour or so. So PK is not great for that compound. But I'm sure that, there's going to be development from the, chemical point of view. And, I'm a chemist as a training at university. So I know that there's a lot of work that can be done from that point of view to optimize compounds. So a few points about toxicity. I'm not going to go through the details. You probably heard a lot about, toxicity of JAK inhibitors. I'm not going to talk about the oral studies that will require a couple of lectures on their own. But just to give you, of course, these are immunosuppressants. So infection, most of the toxicity comes from there. Reactivation of the herpes zoster, especially in patients taking tofa or baricitinib. There's cytopenia in general with anemia, leukopenia, and so on. This is due probably to the effect of JAK2-mediated erythropoietin blocking, but maybe also IL-11, which is also utilized the JAK-STAT pathway, and it's been known to be important for the development of red blood cells. There is an increase in lipids. This has also been seen with IL-6 inhibitors. Acne has been observed, especially in the deucravacitinib trial. Increase in transaminases and GI perforation. If you were at the breakout session yesterday, you probably heard about that. Mechanism we still don't know. Again, job security. And then cancer, the data so far, apart from the oral studies for which I have many concern about, it's similar to biologics. Of course, there more follow-up needs to be done, despite the fact that it's been around for 10 years. And then, of course, cardiovascular risk, which has been associated with some of these, like baricitinib and so on, may be related to thrombopoietin, again, a cytokine that utilize the JAK-STAT pathway, but not sure. How does the selectivity relate to the adverse events? Well, again, it's complicated because, as you can see, tofacitinib decreases the number of lymphocytes in general and NKs. Again, this comes from the same Winthrop review, but some JAK1, JAK3 inhibitors, actually results in increase, for example, of filgotinib, which is another JAK1 inhibitor, results in increase in hemoglobin. We don't understand it. It's a bit complicated. So I think more work needs to be done, because our knowledge is sort of, limited. There are 57 cytokines that utilize this pathway. There's been an attempt to try to tackle that by using machine learning approach. When I saw this paper, when it came out last year, I say, oh, wow, great. This is how we're going to solve it. And it came out in scientific reports. And I think the reason why it came out in scientific reports and not in Science is because, interestingly enough, the group identified some targets. So I show you that the selectivity of JAK inhibitors toward other kinases is quite good in general, even the first generation. But what we didn't show you in that slide, of course, is that the possibility to interact with other proteins in general, so not only kinases. In fact, these groups, by using this machine learning approach, identified other targets. They're listed here: PD8A2, PKN2, and so on. And some of them they narrow on those because of their involvement on particular pathways. That I have listed here. This channel and so on. Interestingly enough, though, what happened is that baricitinib and tofa, baricitinib interacts with PDA10, and so maybe it blocks, but actually if you block PDA10, and these studies were done in animals, actually decreases the risk of thrombosis. So it doesn't really jive on what happens with baricitinib and thrombosis. If you block PKN2, you actually have increased antiviral activity. Again, goes against the logic. And activation of PKN2 is vice versa cause cardiac dysfunction. So what I'm trying to say here is that this was a great idea to use machine learning, but in reality I don't think we understand the whole story completely. So what we learned so far, let me go. Back here. Sorry about that. So we had predicted years ago that these drugs could be, efficacious, and in fact they are. They are utilized to treat many inflammatory disease. We didn't know that selectivity was actually not essential. It turned out, if you have a pan-JAK, it works great, and especially in diseases in which many cytokines, like I show you on my second slides, are important and are involved in the pathophysiology. So pan-JAK inhibitors are viable. JAK2 inhibition is viable, and JAK2 knockout mice do not die. They don't have any blood. They're not born. They die in utero because they don't have any blood. But instead, you can actually use these drugs to treat hematologic malignancies. And, they are effective in other diseases, from viral infection, autoinflammatory diseases, and so on, all things that we didn't know. If selectivity is advantageous or not, I think is still a bit unknown, because is it relevant? Well, it could be yes or no. Yes, if you think, for example, it seems that filgotinib doesn't seem to induce the anemia. If anything, it gets better, and also seems to have less effect in terms of herpes zoster activation. But maybe no, because filgotinib induces a decline in sperm concentration, so it's a side effect, unpredicted side effect. And maybe not, because deucravacitinib also has side effects, because you can use headaches, nasopharyngitis, upper respiratory tract infection, and so on. And another inhibitor, which is TAK-279, was actually recently acquired by Takeda. That's why it changed its name. It was a different name before. In a recent report at the American Academy of Rheumatology meeting showed that 50% of psoriasis patients develop respiratory tract infection. Then maybe yes, because JAK2 STAT3 pathway is protective in terms of myocardial ischemia. So it's complicated, and I'm sorry, I'm going way a little bit too long. There's still a lot of things that we need to know. We need to figure out, the balance between pro and anti-inflammatory cytokines, if we need to better to use in different phases of the disease. We still don't understand which cell type are mostly affected, all things that are work for me. And, a lot of things that are listed here. I think, I don't want to go way too over time. I'll stop here, and I'm happy to take any question.
So I'm very, with mixed emotions here, welcoming our good friend and colleague, Al Kim, who is an assistant professor at WashU, and certainly known so well within the rheumatology community for his work in renal disease, complementopathies, extraordinary work during the COVID pandemic and beyond. He's a commentator for all types of social media, and we are looking forward to entertaining him for the weekend, where he's giving 2 talks. This past week was a major loss in the field of rheumatology with the passing of Rick Brasington. Rick was a major figure in our profession, a colorful man, and much beloved at WashU and in St. Louis. And I know he's a dear friend and mentor to Al, and Al's involved in his memorial services this weekend. So we've taped this, but Al's going to be here today to join us for questions and answers, and we wish him and we wish Rick's family only the best regards. So with that, I've asked Al to start today to talk about complementopathies, and tomorrow he's going to join us for some COVID.
Hi, everyone. I appreciate the invitation to speak about a space that's starting to gain significant traction within the rheumatology world, complement. So I have one disclosure to announce. I've done some consulting work with Alexion, and I'll be discussing some of the data generated and published related to eculizumab, their C5 inhibitor. So before I start, I do apologize for not being there in person. As many of you probably know, the rheumatology world unexpectedly lost a dear colleague, Dr. Rick Brasington, also known as DACO, on May 1st in a fishing accident. He was the program director for the Rheumatology Fellowship at WashU for 27 years, and he was an awardee of the ACR Distinguished Program Director Award in 2015, among many other accolades. Rick was a very important figure in my life. Professionally, he is the reason why I'm in rheumatology, and personally, he was one of my closest friends. And his loss was tragic, but Kitty, his wife, and I have greatly appreciated the outpouring of condolences and remembrances, which has eased our minds. So I dedicate this talk to his life and legacy. So moving on to a decidedly different topic, but one that can elicit equally traumatic thoughts for some. The complement cascade is one of the most ancient. It's found in multicellular organisms as far back evolutionarily as jellyfish, and highly regulated systems in our immune system. Most talks will include a figure like this, showing layers upon layers of complement protein activation. Now, most people don't like complement. I kind of get that. When I was doing my postdoc research, the last thing I frankly wanted to think about was complement. Reason why is simple. I just didn't understand it. I mean, you look at this slide, it's complicated. And this only covers about 60% of the entire cascade. So my goal today is not to dive into every nook and cranny of complement. Rather, I want to take a much more focused view of how the complement system can be perturbed by intrinsic and extrinsic forces to exaggerate complement function that can lead to disease. I will start off with an overview, though, that will lay down a foundation for discussion of several diseases where complement inhibition has been successful, and how those data help contribute to our understanding of how complement contributes to pathogenesis. I have ANCA-associated vasculitis listed here in gray. I know that Dr. Villaforte has already addressed the vacapanda in her presentation, so I will not be discussing it in this one. Now, you will see diseases on this list that rheumatologists typically don't necessarily treat, but I wanted to offer these as examples in order to introduce the biologic proof of principles that may apply to the diseases that we do treat. So as a result, this talk will not break down each rheumatic disease and how complement is involved. To be honest, virtually every pathway has experimental, i.e. animal model, or biomarker data in humans for most of the diseases we treat, which doesn't help me anticipate which inhibitors may or may not be efficacious for that disease. So I decided not to focus any of today's discussion on that particular topic, although it is definitely of high interest to all of us. Also, at the end, I'll be taking a pretty deep dive into a very specific basic science aspect of complement biology that may be important for some of our rheumatic diseases. Again, I do so knowing that the discussion will move to a space where clinical actionability is not immediately clear. But this discussion just serves as a sneak peek into how complement therapeutics may evolve in the future. I also want to acknowledge and thank Dr. Mike Hollers from the University of Colorado. I heard him give a talk similar to the one I'm giving now. And while I have added my own perspectives on the concepts presented today, the spirit of the talk is largely based off of Mike's viewpoints, which is never a bad one to piggyback off of. So I want to thank Mike for allowing me to use some of his slides. So the assessment of complement modulation has been frustratingly slow to take off in the rheumatic disease space for a wide variety of reasons, but there are a number of diseases that already have FDA approval for complement inhibitors, largely using C5 inhibition with monoclonal antibodies. This list of diseases where complement inhibition may be promising is much longer and incomplete on the slide, and the very bottom of the slide, and this includes several rheumatic diseases. Here I show you the dozens of therapeutic assets that modulate complement activation within the portfolios of at least 33 companies. These roughly segment into 6 domains. The 3 canonical pathways of complement activation, classical, lectin, and alternative, and 3 more on the terminal pathway, C5 inhibition, C5a inhibition, and C5b through 9, or MAC, the membrane attack complex inhibition. This is a pretty dizzying array of approaches to inhibit complement activation, but similar to the biologic era that we are in now, this really becomes another opportunity to decipher mechanisms of disease with respect to complement. I mean, for human immunologists, the ability to reduce research the function of a certain cytokine or pathway, what we call knockdown experiments in the research world, it really has uncovered novel functions of well-described cytokines due to the clinical trial data. So, for example, I would say that the role of TNF and granuloma formation in tuberculosis was unknown prior to the post-marketing data generated following the release of TNF inhibitors. So, if we distill the pathways of complement activation, we come up with this paradigm that we're all familiar with. There are 3 main pathways, as I mentioned earlier: classical pathway, lectin pathway, and alternative pathway, all of which converge onto C3 to drive the common pathway, and then the terminal pathway, which is going to be the activation of C5 to generate the membrane attack complex. During this entire process, especially during common pathway, numerous pro-inflammatory molecules are generated, C3A, C5A. They're both very potent anaphylotoxins. They recruit multiple immune cells and drive inflammation. I've listed also on the side here triggers for each of these pathways. And it's not as simple as we've taught it in the past. For example, classical pathway being triggered by immune complexes. Proteins such as C-reactive protein can actually drive this classical pathway activation. Same thing with lectin binding pathway, and then alternative pathway, which we will talk in greater detail during the discussion. And then the functions of these pathways aren't just to drive C3 activation. I think this is best demonstrated by the classical pathway. The classical pathway components, particularly C1q, is critical in being able to clear apoptotic debris. And we know that C1q deficiency is the most highly penetrant reason why you can get a genetic form of systemic lupus erythematosus, and this is because you can't get rid of apoptotic debris, which serve as an extracellular source of nucleic acid antigens. So on this slide is a little more granular look at complement activation, but I want you to focus on the red boxes that are flashing here. The key aspect of complement cascades is its tight regulation by a series of proteins that rein in the strength of complement activation. Especially key here are the proteins within the amplification part of the figure in the middle. I apologize here. So these are going to be factor H, factor I, MCP, and which is stands for membrane cofactor protein, and DAF, decay accelerating factor. You'll hear these terms come up later on in the talk. So the ones in the amplification part, these particularly restrain alternative pathway activation also, which is a part of the pathway that is always on, as I'll talk about later, and can amplify incredibly quickly. So for example, if I took an E. coli bacterium and dumped it into a solution of C3, within 2 minutes, 2 million copies of C3b can be found on that E. coli. So you can see how robust that amplification step is. It's interesting to think about like how important these regulatory proteins are, and you'll see that this is going to be a key feature of how some of our diseases occur when those proteins don't work as well. So at the end of the day, complement plays 3 main roles in immunity and health, and that's listed here in a review by Dan Rinkelin. So first is microbial defense, particularly against bacteria. I just gave you an example of how alternate pathway can really help, clear E. coli. The second one is surveillance. I mentioned before, the classical pathway is really important in being able to clear apoptotic and other cellular debris. And then 3 is kind of more loosely contribution to disease. It's just dysregulation of complement activation that can drive both local and then subsequently systemic inflammation, but also thrombotic events, either through the coagulation cascade and or platelet activation, which then can subsequently lead to organ injury vis-a-vis that cellular damage. So let's switch to the several examples listed here where dysregulation of the complement cascade contributes to the pathophysiology of several diseases. Starting with probably the simplest example, the classical pathway activation by autoantibodies in neuromyelitis optica spectrum diseases. You'd think I'd discuss lupus, the canonical disease that we associate with classical pathway activation, but as I'll discuss later, this may be more nuanced than what we currently teach. Yeah, so just as a brief reminder, NMO is a spectrum of phenotypes that's characterized imaging-wise with diffuse neural inflammation, not too dissimilar from MS, but there's a much clearer association with complement activation that is not necessarily observed in multiple sclerosis. NMO is classically associated with optic neuritis and transverse myelitis, although additional phenotypes can be observed as listed in the figure on the left here. The MRI images on the right just highlight how diffuse the inflammation can be. The spinal cord, brainstem, corpus callosum, and the thalamus, the ventricles with lesional appearances that range from like a pencil-thin epidermal enhancement to like a patchy cloud-like enhancement. All of this can be features of NMO. And just as a reminder, NMO, the primary autoantigen is aquaporin 4, which is actually widely expressed in our bodies. But on the astrocyte end feet, aquaporin 4 is uniquely assembled into these orthogonal arrays. This function of those arrays are not really clear, but that structural macromolecule appears to be necessary to enable the autoantibodies to aquaporin 4 to bind. So the data for complement inhibition treating NMO is absolutely beautiful. Here, anti-C5 monoclonal antibody therapy, in this case eculizumab, clearly decreased first relapse rates, which is the primary outcome measure in these trials. And this is shown in the total study population A, more compellingly in B on patients not on background immunosuppressive therapy, and then in C in people who are on background immunosuppressive therapy. So when you take these data combined with other animal model data and clinical data, there's a pretty clear picture that's painted about how complement drives NMO pathogenesis. So as mentioned before, aquaporin 4 autoantibodies bind to the astrocyte end feet, and that drives classical pathway activation on these end feet. And this eventually deposits the membrane attack complex, which damages the astrocyte, which is the primary pathologic insult in NMO. This then drives secondary damage to oligodendrocytes and neurons and recruits numerous immune cells, macrophages, microglia, neutrophils, eosinophils, T cells, and B cells. And these cells can be found in these lesions also. So interestingly, at the astrocyte endothelial cell function, where the end feet are located, there's actually no expression of CD59, which is a specific regulator of the membrane attack complex. So it seems reasonable that this could contribute to disease. But more importantly to me, it actually highlights that spatial considerations about where complement is activated will have to be considered when understanding what cells and tissues may be vulnerable to damage from complement activation. Okay, so let's switch to another way complement dysregulation occurs. And so this is where genetic variants that can cause complement pathway regulators to hypofunction can drive disease. And this is best demonstrated through the PNH story. So actually, paroxysmal nocturnal hemoglobinuria is actually the first disease targeted by complement inhibitors. So remember, I just talked about CD59 and NMO, that inhibitor of the membrane attack complex. So PNH is a disease where CD59 function is actually lost. So normal red blood cells express CD59, which is tethered to the lipid bilayer of that red blood cell using a glycosyl-phosphatidyl inositol, or GPI anchor. Many proteins are actually anchored to the cell using a GPI anchor. PNH red blood cells lack GPI anchored proteins. So this includes CD59. So continuous complement activation can lead to the formation of membrane attack complexes on the red blood cells. And as pores in the membrane form, water enters by osmotic pressure, and then the PNH RBC swells and ultimately ruptures and hemolyzes. So this is the phenomenon of what we call intravascular hemolysis. So this can then causes a release of red blood cell contents such as hemoglobin and LDH into the plasma. So the hemolysis in PNH is chronic and can lead to multiple clinical sequelae, including severe anemia requiring transfusions, disabling fatigue, shortness of breath and dyspnea, impaired quality of life, recurrent pain, and thrombosis. So it stands to reason that anti-C5 antibodies would make a perfect therapy in PNH. And indeed, this is true. Eculizumab, again, shown here in the TRIUMPH study, which is the crossover extension part of that study, was able to nearly normalize LDH levels when the participants in the placebo arm were given eculizumab, where the arrow is at about week 28. So problem solved, right? Just give them anti-C5 therapy. Well, in exploratory analysis, it was found that there was an inverse correlation between clinical response and the percentage of RBCs that had C3 deposited on them. So what we're going to do is get a little bit deeper dive into complement biology that's critical in understanding what's going on here. Excuse me. And so again, to recap what's going on in PNH, whatever the trigger is for C3 activation, the lack of GPI anchor proteins, here in this case CD59 that we talked about earlier, but also CD55, which is also known as that decay accelerating factor that I mentioned earlier a few slides ago as a key cofactor in blocking and attenuating the C3 amplification loop. The loss of those two proteins allows the generation of C3b accumulation and then subsequent membrane attack complex formation on the RBCs to generate intravascular hemolysis. So when you add eculizumab, this eliminates the entire intravascular hemolysis as I just shown. But this creates a scenario where C3 fragment accumulation occurs. And there's a greater percentage of RBCs coated with C3 complement activation products, such as C3b, IC3b, C3d. And this then actually generates a secondary extravascular hemolysis in the liver and spleen. So if you could attenuate C3 activation, this hypothetically could then block extravascular hemolysis and potentially intravascular hemolysis. And again, indeed, this is the case. So here I'm showing anti-C3 monoclonal body treatment, initially combined with anti-C5 therapy, which restored hemoglobin levels in these patients with PNH. But when anti-C5 therapy was then used only by itself, following this run-in period, you can see the hemoglobin levels dropped, and this is all due to extravascular hemolysis, while use of anti-C3 therapy was able to both block intravascular and extravascular hemolysis and then maintain normal hemoglobin levels. So, of course, I can't ignore the elegant mechanistic studies that one of my mentors, John Atkinson, had done while he was at NIH in the 1970s with Mike Frank, that elucidated how extravascular hemolysis occurs. And they use cold agglutinin disease as the model. So in cold agglutinin disease, the cooling of red blood cells as they passage through peripheral vessels allows for IgM cold agglutinin antibodies to bind to red blood cells. And this agglutinates and activates the classical pathway on those red blood cells, causing eventually the deposition of C3b on that red blood cell surface. As that red blood cell returns back to central circulation with subsequent warming, IgM is removed from the serum and the agglutinating cells start to detach from one another. The C3b remains bound and then activates C5, leading to the formation of the MAC and intravascular hemolysis, which seems to be a role that is important for acute exacerbations of cold agglutinin disease. But in the steady state, phagocytosis of C3b-coated red blood cells by the reticular endothelial system in the liver and spleen is the predominant pathway, and this is what we call extravascular hemolysis. So intrahepatic C3b conversion leads to the deposition of C3d on surviving erythrocytes, which then are released back into the circulation, saving some of the red blood cells from hemolysis. So while patients with PNH are treated with anti-C5 therapy and accumulate C3 products in red blood cells due to unchecked C3 amplification from the lack of decay accelerating factor, which then drives extravascular hemolysis, those with cold agglutinin disease activate C3 through the classical pathway. So you can speculate that if we had a classical pathway inhibitor, this may work for people with cold agglutinin disease. And indeed, again, this is the case. So antibodies against the C1 complex, specifically here to C1s, is effective in cold agglutinin disease in blocking both intravascular and extravascular hemolysis. So I think the lesson to take from this section is that perturbations within the system never really result in an isolated result. As in the case of all physiology, adaptations are made within these complicated systems that may not have any physiological or clinical impact, or it may have an impact. And this is certainly the case that's observed in PNH. Another phenotype that's associated with genetic variants driving dysfunctional complement activation are the thrombotic microangiopathies, or the TMAs. So, TMAs are a little bit confusing. It's really more of a phenotype. You have to find the underlying cause. It's characterized by MAHA, or microangiopathic hemolytic anemia, and thrombocytopenia, which then can lead to organ damage due to thrombus formation within arterioles and capillaries, with classic onion skinning of the arterioles and pathology. So there are multiple root causes of TMA, as shown in this pretty complicated diagram created by the KDIGO group. We generally dichotomize TMAs into primary, which are largely due to loss of function variants in complement regulatory proteins, and secondary causes, which are associated with a wide list of diseases and infections on this chart. Now, there's actually data that just got published this past Wednesday in Clinical JSON that has shown that many of those with secondary TMAs also have variants predicted to generate loss of function of complement regulatory proteins. And again, this was speculated by the KDIGO group here. So this slide just shows a small smattering of data supporting how genetic variants in the complement regulatory proteins can drive TMAs. Many of these were identified in patients with atypical hemolytic uremic syndrome, or AHUS. But as you can see here, the most prominent variants affecting regulation of the C3 amplification loop, including factor H, factor I, and CD46, also known as membrane cofactor, were also mentioned, have also been identified as being associated with aHUS. And of course, the end result of the formation of amplifying the C3 is going to be formation of the membrane attack complex on endothelial cells, driving injury and microthrombosis. So as a result, it's not too surprising that anti-C5 therapy has been quite effective in the TMAs. Again, using eculizumab in those people with atypical hemolytic uremic syndrome with renal injury. The clinical outcome measures, platelet counts, eGFR, they were normalized following treatment. So similar to those with PNH, in TMAs, excessive alternate pathway activation drives membrane attack complex formation on endothelial cells in this particular case. And this can be blocked by, C5 blocking antibodies. Now, why PNH doesn't also have an endotheliopathy phenotype is not clear to me. I'm not smart enough to answer that question. So TMAs do occur in autoimmune diseases, and that's highlighted in the red box on the left side there. Yeah, antiphospholipid syndrome and scleroderma renal crisis are classic examples. But I think we've also underdiagnosed TMAs in a lot of other systemic autoimmune diseases, particularly in lupus. So our TMA expert here at WashU, Anuja Java, and I recently wrote a perspective about TMAs and systemic autoimmune diseases for those who are interested, and I've listed the reference on the bottom right of the slide. Okay, so let's wrap up here with a related issue to the discussion that we just had, but a more specific and a different trigger for the alternate pathway. That is neutrophils, and we're going to focus the conversation initially on antiphospholipid syndrome, although I believe systemic lupus erythematosus and ANCA-associated vasculitis may fall into this category also. And then we'll then also expand into some basic science that may give us an additional understanding of what's going on here. So as I just mentioned, antiphospholipid syndrome is one of our classic endotheliopathies, or at least that's what I call them, where TMA is a prominent feature. Some of the work shown on this slide comes from Jason Knight and Ray Zhu at the University of Michigan. Both of them have also done substantial work with COVID. Summarizing decades of what's known about the interplay between complement neutrophils and endothelial cells. On the left side here, I show basically this triad where complement activation through whatever trigger it may be will generate pro-inflammatory the polypeptide C3 and C5a that again recruits the neutrophils as well as monocytes to the area. These activated neutrophils generate those web-like neutrophil extracellular traps or nets in a process known as netosis. And nets actually contain components such as C3 and factors that activate the alternate pathway, propyridin and factor B. So although nets assist in host defense against pathogens, a sustained response could also incite ongoing inflammation in a hypercoagulable state. In addition, the membrane attack complex will also induce endothelial cell inflammation and tissue injury. And this can then further generate pro-inflammatory cytokines such as IL-6 and IL-1 beta, which also can propagate netosis. Now, the endothelial cell injury that I just described leads to a couple of different things that can drive coagulopathies. First is the generation of von Willebrand factor multimers. Excess ultra-long von Willebrand factor stabilizes factor VIII activity and prevents the binding of factor I, which is actually one of those regulators of the C3 amplification loop. So you get kind of a positive loop there. The other aspect about endothelial damage is that it releases plasminogen activator inhibitor 1 or PIA1, which exacerbates thrombosis. And this, along with C5a-induced release of tissue factor and other prothrombotic proteins, creates a hypercoagulable milieu. So these changes then, though, can also further augment complement coagulation pathway crosstalk. So using thrombin and kallikrein to further activate complement system in a convertase-independent manner. So you can see this, it can be a very nasty process. The endothelial cell injury, the hypercoagulability, the complement activation, and all contribute to tissue damage and are associated with TMAs. So I listed on the right side here the pretty substantial amount of work, mostly done through Jane Salmon's effort at HSS, demonstrating the required role of complement in antiphospholipid syndrome. And in anecdotal reports in the last bullet point there, anti-C5 therapy has been used with some success in these patients. Okay, so why am I going through all of this? So we're going to get into some really deep weeds of alternate pathway activation and give you some of my own perspectives of what's going on. And it's going to require a journey into basic science. So even though I've given you a few examples where alternate pathway is critical in disease, in all rheumatic diseases, we almost attribute everything to classical pathway activation because we have autoantibodies. And to be honest, I'm not sure if we're right about that. If I were to bet a little bit of money about which pathway may yield the highest rate of success in terms of blockade and attenuation of disease activity for our rheumatic diseases, I'm going to make an argument it might be alternative pathway. Okay, so let me try to justify that unsubstantiated statement. So to do so, we have to look at the details of C3 activation. And I'm going to apologize in advance because this gets really deep. Alternative pathway actually gets started by this conversion of native C3 into a species called C3 water in a process that us complementologists have termed tick over. This is the presumed spontaneous and constitutively active process that can rapidly amplify with the right trigger. Remember, I told you earlier about E. coli and the 2 million copies of C3b that gets deposited within 2 minutes. Once C3 water is formed, then other activating factors, factor B and factor D, create the initial alternate pathway for alternate pathway C3 convertase, the C3 water BB. This then takes other native C3 and creates C3A and C3B. That C3B actually has 3 separate fates. First, it amplifies this alternate pathway by making more C3 alternate pathway C3 convertase. In this case, it's not going to be C3 water BB, but rather C3B BB. The other fate is that it helps create the C5 convertase to continue the pathway. Or fate 3, it is metabolized and broken down by factor H and factor I to shut down the alternate pathway. Remember, I've already talked about factor H and factor I as proteins where the loss of function has occurred and is associated and likely causal in diseases like atypical HUS. Now, what's interesting about the conversion of native C3 to C3 water is that this is the rate limiting step for the alternate pathway. It's been estimated this occurs at a level that's relatively low, about 1% of our native C3 spontaneously gets converted to C3 water. But the interesting thing about that conversion is that all it is really a substantial conformation change as outlined in this cartoon in the bottom. So the once C3 flips several domains open, there's a very highly reactive thioester bond that within microseconds binds to any nucleophile around it. And so typically this is water. So when C3 activation occurs, 10% end up on the bacterial surface or our own cells, whereas 90% end up in a fluid phase, which we call C3 water. And this is just simply a flipping of the C3 molecule. So our lab got interested in this conversion after a few conversations with John Atkinson. So John is a brilliant storyteller, and he was telling me stories about how they made C3 water in their lab. Decades ago, they generated C3 water literally by blowing air through a straw into a solution of native C3. Of course, now we can't do that. But instead, they actually do multiple freeze thaws of native C3 solution. And then after, say, 5 or 7 freeze thaw cycles, you can make a solution with 90% C3 water. Then we ran into this commentary cited at the bottom of the slide, where they speculated other surfaces such as polystyrene could also trigger this conversion. Okay, so what's going on here? What's the common link? Polystyrene is a very highly negatively charged surface. And what's interesting about air and water, like blowing air into water, is that the water molecule, when you blow air into it, orients itself in this way that the hydrogens that are going to be positively charged point towards the bubble. And then the negatively charged oxygens are pointing away from the bubble. So this is actually our negatively charged surface, and that's pretty interesting. Then what about freeze thaws? All right, so water is a weird molecule, and the only one to my knowledge that has the solid phase being less dense than the liquid phase. I mean, if you obviously drop ice into water, it floats. So how does it become less dense? The introduction of air. So of course, the kinetics are dramatically reduced at these colder temperatures, which is the reason why multiple freeze thaws are needed to generate a high yield of C3 water in the lab. But in a person, we don't have air bubbles floating around that can drive the formation of C3 water. What would be a physiologic source of highly negatively charged material? Well, this is where neutrophils come into the picture. DNA, by definition, is an acid, a weak acid. And at physiologic pHs, that proton is lost, which makes DNA a very highly negatively charged molecule. And in many of our diseases, neutrophils have been implicated. And just as a reminder again, one of the cardinal processes of neutrophil activation is netosis, which we briefly discussed earlier. Netosis is literally when the neutrophil barfs out its own chromatin and it coats itself with its own DNA. And so in diseases like antiphospholipid syndrome, through the work of Jason Knight, and systemic lupus erythematosus through the work of Mariana Kaplan, netosis is on overdrive and is a prominent immunologic feature of both conditions. So when we activated neutrophils and added native C3 to them, we can see on this area scan confocal microscopy image on the right is that C3 in red co-localizes with nets that are marked with histones in green. And the overlay of the red and green being orange shows that there's a potential interaction between the C3 and the nets. So we immediately thought of whether or not nets were sufficient to drive alternate pathway activation by accelerating that rate-limiting step of C3 water formation. So leveraging a novel ELISA created by Michelle Elvington, who was a postdoc in John's lab, that could accurately measure C3 water, we asked a simple question whether or not nets can drive the formation of C3 water when native C3 is added. So we did this a couple different ways. On the left side, Jason Knight introduced me to his collaborator, Priyan Ripapuri, who invented artificial nets, which he termed DHMs, or DNA histone mesostructures. These DHMs have structural and biologic characteristics identical to real nets. So you can see in the bottom left bar graph, when we added native C3 to these artificial nets, within 5 minutes, about 90% of the native C3 was converted to C3 water, which is remarkable. To confirm that this was sufficient to drive alternate pathway activation, we added human sera where C4 was depleted from it. And this ensures that any classical or mannose binding lectin pathway activation could not occur. And the only way that you would be able to activate C3 here would be through alternate pathway. Here, we saw elevated levels of BB, a byproduct of factor B activation, and a specific marker of alternative pathway activation. So using these artificial nets, we were able to find that C3 water is generated, and that's sufficient to drive alternate pathway in the lab setting. We found identical data using isolated real nets from obtained from activated neutrophils from healthy donors. And again, we saw nearly instantaneous conversion of native C3 to C3 water and elevated BB levels. Importantly, when we added an enzyme that could break down DNA, appropriately called DNase, no C3 water was formed, no BB was generated. So this really strongly suggests that in potential diseases where netosis is a feature of it, you may have exuberant alternative pathway activation simply because of the charged surface of the chromatin. So we're always trying to find newer ways to block all the various inflammatory pathways associated with rheumatic disease. And our group is no different. The data I just presented, in my mind, pretty clearly supports that this rate-limiting step to alternate pathway activation, the conversion of native C3 to C3 water, is greatly accelerated by the simple contact of native C3 to chromatin found in nets. So to me, the therapeutic innovation here would be to see if small molecules could block this interaction and whether and apply it in diseases where we think this process is occurring too quickly. So what you're seeing is the first rough draft cryo-EM image of native C3 as it wraps around chromatin. I removed the chromatin because it got a little messy, but you can see kind of this groove here, and that's where the DNA actually would be located. I have to thank Dave Karp at UT Southwestern for this idea to look at this. Once we get a much cleaner image of this, this image is at 3.6 angstroms. What we can do is easily model in libraries of small molecules to see if this conversion can be inhibited and possibly be used as a therapeutic. Okay, let's wrap up here. We took a long, winding journey through complement, and to be honest, we only skirted, several surfaces of it. This therapeutic space is exploding. So what I presented, it really is just the tip of this iceberg. We went through several diseases where dysregulation of complement pathways contribute to pathophysiology, and even explored some of the basic science that, may have a glimpse into the future. There are two other topics I'm not going to cover today, but need to be mentioned just so you are, you have a contemporary understanding of complement. The first one is this new system that's relatively controversial called the intracellular complement activation system, also known as the complosome. I know you're thinking, wait a minute, it's, the extracellular complement activation pathway is complicated enough. There's an intracellular pathway, yes, and actually work that Claudia Kemper had done while she was in John Atkinson's lab almost 10 years ago, showed that T cells, as they move from a unpolarized phenotype, what we call Th0, to a more pro-inflammatory phenotype, a Th1 T cell, intracellular complement activation was absolutely required for that, which is fascinating. And there's a lot more work being done by multiple investigators showing that even non-immune cells, such as lung epithelium and cells in the kidney, can make their own C3. It excretes it out where it gets converted to C3 water and then gets brought back into the cell, which then can generate functional responses necessary for homeostasis of that organ. So again, this is a very nascent field, and there are complementologists that actually don't really believe in this system either. Although I think the totality of the data is strongly suggesting this is something that is real and that may be targetable. And this is something we are looking at in our group too, within the context of lupus. The next one is a little bit more tangible. Our biomarker discovery process in rheumatology is not very well coordinated, and this is certainly true with complement. We do have some, of course, the legacy complement tests, C3 and C4 measured by nephelometry. But, there are newer ones. Exogen has their C4D CAPS product for red blood cells, EC4D and B cells, or BC4D. But we don't really have a lot else, even though there are over 50 things that we can measure. So, expanded analyte panels for complement activation products are probably going to be needed. And so I think we could actually, because there's so many components there, we could potentially have personalized signatures of complement activation be identified, which may actually potentially instruct us about therapy. Now, you may say, well, I use complement all the time in lupus, and it seems to work fine as a biomarker. I'm going to challenge that. And this is going to the last point I'm going to bring up today. So this is data from our own lupus center when we just said, okay, we're going to look at active lupus patients versus inactive lupus patients. We use the SLEDAI using a threshold of 0 to 4 for inactive, greater than 4 for active, and just look at their C3 levels at the time of clinical assessment. The data is not very good for C3. Yes, if you have a low C3, about 3/4 of those people will have active disease. And that's consistent with what we think, although it's only 3/4, it's not 100%. What's more concerning, though, is that for people that have active disease, the majority of them, about 70% of them, have normal C3 levels. And we have similar data for C4. I think a large reason why is that C3 and C4 are also acute phase reactants. So as soon as you make IL-6, right, and that IL-6 then signals through the IL-6 receptor alpha chain, GP130 on the hepatocyte, you start the acute phase reactant program, you make C3 and C4 systemically. So while you're consuming it at the tissue level, your liver is dumping it and replacing it at the system level. So you end up having normal levels, even though they are flaring. So again, this is a potential avenue for a lot of innovation in terms of biomarkers to be able to find more specific markers of activation and see whether or not this correlates with disease. So I appreciate the attention, and I'll be happy to take any questions. Thanks.